The topic of Chapter 15 is exercise tests to evaluate cardiorespiratory fitness. In this lecture, we'll look at testing procedures, field tests for estimating cardiorespiratory function, and we'll look at graded exercise tests. Many people in the United States could benefit from an increase in physical activity. We have a very high rate of chronic diseases such as heart disease and diabetes. It's well known that physical exercise may help people that have chronic diseases. However, starting an exercise program needs to be done in a safe manner. Therefore, before beginning an exercise program, cardiorespiratory function, or CRF, needs to be measured. One method is to use a graded exercise test, or GXT, to measure VO2 max. A graded exercise test can also be used to measure heart function, for example, the 12-lead electrocardiogram. And furthermore, the choice of graded exercise test depends on the person. So, for example, we would give a different test to a young, healthy person versus an older person with coronary heart disease. For certain diseases, such as high blood pressure, there's actually a significant risk of the person having a cardiac event during the exercise testing itself. Therefore, extreme care has to be taken in designing the fitness test. And we'll see in subsequent slides, we'll talk about questionnaires that the person would answer. And we'll also talk about designing submaximal exercise tests that would allow us to assess their cardiac function without actually putting them at risk. One of the first steps for getting a person more active is for them to take a questionnaire. And I'll first describe the original PAR-Q test. On the original PAR-Q test, there were 7 questions that would ask the participant about various risk factors. If all the responses to all 7 questions were no, then the person would be allowed to participate in an exercise test and begin a physical activity program that's appropriate to them. However, on this original test, if there was a single yes response, then the person was then directed to go see a doctor before proceeding further. Now, the problem with this original PAR-Q test was that a very large percentage of people were being inappropriately directed to see a doctor, and this would slow down the process of them getting started with physical exercise. So because of that, a newer test was devised, which is the PAR-Q plus test. So I should explain what this PAR-Q stands for. So it stands for Physical Activity Readiness Questionnaire, and the plus is the newer version. With this newer version of the questionnaire, there were additional questions to clarify the nature of a problem. In other words, if they answered yes to one or more of these questions, they would then be directed to additional questions. If they then answered no to the additional questions, then the person was then allowed to proceed to the appropriate exercise test and physical activity program. If they did answer yes to any of these other additional questions, they were then directed to see a physician or to take another test, which is the ePARmed X test. And this is an online questionnaire that gave further, would clarify certain risks and so forth in greater detail. And at that point, then maybe they would still be directed to see a doctor, and then they would see how they would proceed next. But the main point was with this the newer, more modern test, the PAR-Q plus test, only about 1% of individuals were directed to see a doctor. And this is good because this would allow them to start physical activity sooner and start to see the benefits of the physical activity. So you can see here an example of the PAR-Q plus test. There are questions, for example, asking about heart condition, chest pain, loss of balance or dizziness, and various other things. An alternative approach for screening participants for physical activity is proposed by the American College of Sports Medicine, or ACSM. There's a new ACSM exercise health screening process that's based on the individual's current level of physical activity, the presence of signs or symptoms and or known cardiovascular, metabolic, or renal disease, and also the desired exercise intensity. And the aim of this is to reduce the barriers to participation in exercise while still addressing the risks to those with known or suspected chronic disease. Here's a flow chart outlining the logic of the ACSM guidelines. So first of all, let's take the case of an individual who's not been diagnosed with cardiovascular disease or CV, metabolic or renal disease, and who does not have symptoms of these diseases. Now, whether or not this person exercises, so we basically have split this into two. This is participants that don't do regular exercise. Well, if they don't have any of these signs or symptoms, they don't have a known disease, they don't have any signs or symptoms, then they're medically cleared. So they can begin exercise without medical clearance. In other words, they don't need to see a doctor. And then they can gradually progress to more vigorous exercise. Now, for a person who has no known cardiovascular disease, metabolic disease, or renal disease, and they show no signs or symptoms, then they're also cleared. They don't have to go see a doctor. And they can continue with the moderate exercise, and they can gradually progress following in terms of intensity to higher and higher intensities following the ACSM guidelines. Now let's take a case of an individual who does have signs or symptoms of cardiovascular disease, metabolic, or renal disease. So in that case, here's a person, for example, who doesn't exercise. They're showing signs or symptoms. Well, they should see a doctor. Medical clearance is recommended. And once they get that, then they can start with light exercise, and they can gradually increase in intensity. Now, if a person has signs or symptoms and they're already exercising, well, they should discontinue exercise and then seek medical clearance. And then, assuming that goes well, they can then return to exercise following medical clearance and gradually increase in terms of the exercise in terms of intensity following the ACSM guidelines. Finally, the last category is an individual with a known cardiovascular disease, metabolic or renal disease. So that would be here. This person doesn't exercise, but they're asymptomatic. In other words, they're not showing any any real signs of this disease. Then this medical clearance is recommended for an individual who isn't actively doing regular exercise. Once they get the medical clearance, they can start with light exercise and gradually increase in intensity following the ACSM guidelines. All right, for someone in the same situation, but they do regularly exercise, so they have a known cardiovascular, metabolic, or renal disease, but they're asymptomatic, then they do not need medical clearance. Medical clearance for moderate intensity exercise is not necessary. However, if they want to go to more vigorous intensity exercises, in other words, they want to go to a higher level of exercise than they've been doing routinely, then they should seek medical advice. And assuming that goes well, they can then continue with the moderate intensity exercise and then potentially increase the intensity, assuming that they're cleared for it. If we assume that an individual has been cleared for an exercise test, then we still need to think about the individual as being in a risk category. So they may be low risk, moderate risk, or high risk. So low risk would be a healthy person in this case, and they have no signs or symptoms whatsoever. A medical exam and graded exercise test are not needed before beginning an exercise program. In other words, they could just start right away. And if physician supervision is not needed during a graded exercise test. So say they were to request a graded exercise test, well, they could go ahead and do it since they're low risk. So for example, this woman, let's assume she's low risk, she could go ahead and do a graded exercise test on the cycle ergometer. In this case, she set up for them to record her ECG or electrocardiogram. Okay, now let's look at a moderate risk person. For a moderate risk person, a medical exam and a graded exercise test is recommended prior to vigorous intensity exercise, but not before moderate intensity exercise. So in other words, they can start exercising, but only up to moderate exercise without any sort of test. They may choose to do a graded exercise test, and physician supervision is not needed during maximal or submaximal graded exercise test. Now, the highest category is a high risk factor person. So this person would need a medical exam and a graded exercise test before beginning any exercise. Furthermore, physician supervision is recommended during either a submaximal or maximal graded exercise test. Next, let's look at some of the things we'd actually measure. First of all, we can do resting measures. So if we have a patient or a subject, we could measure their heart rate and blood pressure just at rest. That would give us some indication of their level of fitness. We can also do a blood serum test to look at their cholesterol levels. And we could also do a resting electrocardiogram. So we'd measure their heart rate and look at the various electrical activity parameters in a person at rest. Now, of course, for a person at rest, their body's not really pushed very much. In other words, most of us have spare capacity in terms of heart rate and respiration and so forth. And so we really won't see a lot necessarily with a person at rest. We may, if they have high blood pressure or something like that. And so those are certainly useful measures. But we may not really see what's going on with their body until we actually essentially stress the body a little bit with a little bit of exercise. So there's different things that you would do, but you would measure some of the same parameters. You might measure heart rate, blood pressure. Again, ECG would be something to measure. And so, for example, you could do a graded exercise test in which heart rate is measured at each step of the test. So they would exercise a bit, you'd measure heart rate, and then they'd exercise at a slightly higher intensity, then you measure the heart rate, and you keep going back and forth like that. And the test would progress from light exercise to a predetermined endpoint, such as 70 to 85% of the predicted maximal heart rate for that individual. The other endpoints for a graded exercise test might be exhaustion. They could be symptoms such as chest pain, such as angina pectoris, which is indicative of perhaps hypoxia in the myocardium. Breathlessness, which is called dyspnea, would be another symptom that might lead you to end a graded test. And graded tests can be done many ways. You could do them on a treadmill, as shown here in this picture. You could do you could use a cycle ergometer. You could use a step bench to do aerobic exercise. And they're all different ways to vary the work rate for all three of these different methods. In addition to graded exercise tests, which give us indication of cardiorespiratory function, we can also use field tests. Field tests are a bit different. Typically, a person is either asked to do exercise such as running for a certain distance, or they're asked to do an exercise such as running for a certain amount of time. And then we would measure things like heart rate and so forth. And this would give us, and we'll go into more detail about the field tests and the graded exercise tests. But either way, with either a graded exercise test or a field test, we get some idea of the level of fitness of the person. So here are the take-home messages. The steps to follow before conducting an exercise test is to evaluate the cardiorespiratory fitness of an individual include the following. First of all, review the health history for known diseases, signs and symptoms, and risk factors. Stratify the level of risk. And finally, determine the type of test and level of supervision needed. Let's first take a look at field tests for estimating cardiorespiratory function, or CRF. One of the big advantages of field tests is they use fairly natural activities such as walking, running, or stepping. You can test a large number of people at low cost, often at the same time. And and there's a moderately high correlation with VO2 max. In other words, we can measure various parameters, and then we can sort of use charts or equations to figure out what the VO2 max of the individual would be. There are, however, some disadvantages to field tests. First of all, physiological responses may be difficult to measure. If the person's out running on a track or something, it's hard to measure ECG or heart rate very easily in a continuous manner. So maybe you can measure heart rate at the end of, say, 12 minutes of running, something like that, but you can't really measure it continuously the way you would be able to in a lab. Another disadvantage is motivation. So obviously there's different levels of motivation between different people. So someone who's highly motivated will show up as being more fit than a person who's actually fit but just less motivated to really push themselves. So this brings us to this last disadvantage, which is the tests are not graded. They're generally going to be maximal tests. So we're trying to get the individuals to really push themselves. And that gives us a better idea of where they stand in terms of cardiorespiratory function using these field tests. So finally, field tests usually should be done with a person who's progressed through a series of exercise at lower intensity. So this wouldn't be something you necessarily would do with someone who already has known risk factors for, say, cardiac disease or something like that. Field tests are generally going to work better for healthier people. Now, I will talk about some ways you can get around that. For example, there are field tests in which we ask people to walk. However, even with those walking tests, the people are asked to walk very quickly, very briskly. So these are generally going to be tests that sort of push people a little bit to their max. And so it's not necessarily appropriate for all people. The most popular field tests are maximal run tests. These measure how far a person can run in a set time or how fast they can run a set distance. So for adults, Cooper's 12-minute run is extremely popular. The people, they run for 12 minutes, and then you measure their heart rate at the end of the 12 minutes. And they're expected to run basically as fast as they can. So it's a maximal exercise. The other possibility is having them, Cooper has a test also, which is a 1.5 mile run. So they have a set distance, but now they're going to run that distance as fast as they can. So some of the tests that work well for adults don't work as well for children. So some tests have been developed to work with children. So there's the AAHPERD's 1 mile run walk. AHPERD stands for American Alliance for Health, Physical Education, Recreation, and Dance. So that's a very good test for children. They do need some instruction on how to pace themselves and stuff with this run walk. But other than that, it works very well. And then there's the PACER test. And the PACER stands for Progressive Aerobic Cardiovascular Endurance Run. And we're going to talk more about that later. But both of these are very good tests. They work really well with children to measure their fitness. And we'll talk about some of the special differences between children and adults. Basically, children, particularly very young children, their economy of running is not as high as adults. In other words, they're not as efficient in terms of their running ability. And so that has to be taken into account. So the goal with many of these tests is to try and calculate a VO2 max. So recall that there's earlier on, we talked about the fact that there's a linear relationship between VO2 max, which is milliliters of oxygen per kilogram per minute. So it's a rate of oxygen consumption per minute, and it's normalized for the weight of the person. That's why it's per kilogram. So there's a linear relationship between VO2, the oxygen consumption, and running speed. And so VO2 max is also going to be on that line. And so potentially, if you have a line, you can even estimate VO2 max a little bit if you have a submaximal exercise. And we'll talk about that later. But in order to get the best estimate, you're going to want to have the people running at a speed that demands about 90 to 95% of VO2 max. And that duration is typically for these tests about 10 to 20 minutes. And the reason for this is that if the person runs for less than 5 minutes or less, they can rely a lot on anaerobic metabolism to generate the energy they use during that 5 minutes. And so they would essentially spend a lot of energy, but it's not really a good indication of their aerobic capacity because they're relying on anaerobic means of energy generation. So this would tend to overestimate the cardiorespiratory function. Now, 20 minutes seems to be about the max, because if this individual start running more than 20 minutes, then most people, unless they're trained athletes, are not able to maintain that high level of VO2 max. In other words, we want to keep them in the range of 90 to 95% VO2 max. And most people simply can't sustain that unless they're trained athletes for such a long period of time. So that's why this duration of 10 to 20 minutes seems to work very well. So with one of these tests, we can calculate the average running speed. Let's say it's the 12-minute test. So we would calculate the average running speed over that 12 minutes. And then we can plug that into an equation and figure out what VO2 max is. We actually did this way back in chapter 1. So this is an equation from chapter 1. It was in the section Closer Look 1.1 on page 24 of the textbook. So recall that, again, VO2 max, VO2, where the oxygen consumption has units of milliliters of oxygen per kilogram per minute. So we should see the correct units here. In fact, we do. So VO2 here equals and 0.2 multiplied by milliliters of O2 per kilogram per minute. And we're going to divide this by meters per minute. Okay, so that's a big there's a division sign here. We're going to multiply this by speed, which is in units of meters per minute. Notice that the meters per minute here is in the numerator, and this meter per minute here is in the denominator. So those cancel out, and we have the correct units of milliliters of oxygen per kilogram per minute. So that's taking into account the speed, which is you plug in speed here, and we'll do an example in a second. And then we're going to add 3.5 milliliters of O2 per kilogram per minute. Recall that even when a person isn't exercising, they're of course using oxygen. You're always using oxygen to breathe, for the heart to beat, for the brain to work, and so forth. So this is the basal metabolic rate. And so that's this is just sort of an average value for an adult. So we can plug these values in. So let's imagine that we have an adult who's running at a rate of 161 meters per minute. Then we essentially just plug in this one number. And then if you do the calculation, we get VO2 equals 35.7 milliliters per kilogram per minute. And recall that we asked the person to run as fast as they could. So we're assuming that they're about at 90 to 95% of VO2 max. And so this value then is 35.7 milliliters of oxygen per kilogram per minute is in fact a VO2. It's our estimate of VO2 max. Okay, if you were going to do this Cooper's 12-minute run or the other Cooper's test, which I believe was 1.5-mile run, neither of those is really going to accurately capture the ability of prepubescent children. And that's because they have a lower economy of running compared to adult. So it underestimates the VO2 max because essentially they're not running as efficiently, but everything else is working fine. So their cardiorespiratory function is actually quite good, but they're not as efficient with running. So for this reason, there are alternative tests. So for example, for first to third grade children, one example of an alternative test is a 1,600 meter run. That's a pretty good predictor of measured VO2 max scores. In other words, they did a study where they did actually measure VO2 max carefully in a lab, and then they compared the performance of these children in this age group with different distance runs, And this 1,600 meter run was actually the best predictor of the VO2 max. And we'll also see other cases. So for example, there's also a 1 mile walk run test. That's also a very effective test with children. So getting back to tests with adults, imagine that the adult is doing a walk test. Then we can't use the same formula that we used before. It's a very similar formula, but instead of 0.2, we're going to have 0.1 multiplied by the walking speed. And then of course, the basal metabolic rate is no different. So, and the reason for this, instead of 0.2, it's 0.1. And the reason for this is because walking is essentially more efficient. So there's less energetic cost to walking than running. So for example, the O2 cost of walking at 80 meters per minute is 0.1 multiplied by 80 plus the 3.5. So you get 11.5 milliliters of O2 per kilogram per minute. I should point out that here this VO2 is not a VO2 max. Presumably the person's walking isn't working at the high rate that they would be if they were running at 90 to 95% of VO2 max. We will look at a test a little bit later on in which you can try and estimate VO2 max from walking, but that's not with this formula. This table allows for the comparison of an individual's VO2 max with other individuals of the same age and sex. For example, we could take the VO2 max of 35.7. Let's say it's for a 20 to 29-year-old woman. And if we look at this chart, we would see that 35.7 is right here. So it would put her between the 40th and 45th percentile for women that age. So one of the points, so this is useful just to get an idea of where an individual stands relative to other individuals of the same age and sex. But one of the things that one caveat with this is that there are differences of economy of running between individuals, and also there are differences in terms of motivation, which I've talked about a little bit earlier. So this makes a comparison of VO2 max between individuals a little bit unreliable and difficult. So one of the best uses of fitness tests actually may be to compare an individual to him or herself over time. And then this would be quite accurate, right? Because the person would have the same economy of running and the same level, more or less the same level of motivation. So you could see if they're progressing in terms of their fitness. As I mentioned previously, some of the tests that work really well for adults don't work as well for children. For this reason, alternative tests of aerobic fitness have been developed for school-age children. One is the Progressive Aerobic Cardiovascular Endurance Run, or PACER test. And this test is part of the FitnessGram testing battery. There's a whole series of tests that can be done. And this FitnessGram program has been developed by the Cooper Institute. This PACER test is a 20-meter shuttle run test. The students move between two boundary lines, and the pace is set by an audio recording. The students must run from one line to the other between two beeps, and the time interval between the beeps becomes progressively shorter. And so eventually what happens is certain students can't keep up and they'll drop out. And you know at what point they drop out, and then we can use the number of laps to determine their aerobic fitness. So this is a very good indicator of cardiorespiratory fitness. And you can obtain VO2 max values that are very similar to those that would be measured with a treadmill test in, say, a lab. So for example, in a study of 10 to 15-year-old children, the VO2 max value measured with the PACER test was very similar to those measured with the treadmill test. In addition, there was no difference in the maximal heart rate. So these results indicate that the PACER test is a good indicator of cardiorespiratory fitness. So in the past, the standard way to evaluate the fitness level of a child is to use normative standards. A normative standard allows for a child's fitness score to be compared to the values derived from his peers, yielding a percentage score. So, for example, a child might have a certain VO2 max, and that might yield a 75th percentile score, which means that he's doing better than essentially 75% of his peers or her peers. Now, there's a little bit of a problem there because you're constantly comparing people one to another. And again, we've talked about things like there's maybe a difference in terms of economy of running between individuals and things like that, and motivation. So another way to look at fitness is to just say, well, what's the minimum, what's a certain level of fitness that we would deem sufficient for good health? And so this is a sort of a different way of looking at it. So, for example, if we look at adults, we find that, yeah, you could figure out where you stand in terms of a percentile for other people of your age and sex, but that's not necessarily all that predictive of how you are in terms of health. What's really important is that you meet a certain level of fitness. And if you're above that level, then your risk factors for, say, cardiovascular disease and so forth are actually quite low. So it's the same standard here, the same sort of idea that you just want to have some sort of minimal level of fitness that's consistent with good health. So, for example, the Fitness Gram evaluation program has come up with a set of standards for children. So, for example, they found that a VO2 max standard for boys aged 5 to 17 years old is 42 milliliters of oxygen per kilogram per minute. So as long as they meet that standard, they're fine. And so the tests they would do something like they'd run for a mile, translate that their time into a VO2 max value, and then just see how they compare with that criterion. And this also can take into account things like improvement of economy of running with age. Now, one problem with a run test, of course, is it doesn't work very well with someone who has perhaps joint pain or something like that. But maybe a person like that would be able to walk briskly. And so what you could do is a walk test. So there is a 1 mile walk test that is quite simple to do, and it's also quite effective. And so in this test, the subject walks for as fast as possible for 1 mile on a flat track. And then their heart rate is measured at the end of the last lap. And then based on that heart rate and the time that they took, we can then figure out what their VO2 max was. So, for example, here's the equation. VO2 max is based on a bunch of numbers here. We also have to put in their weight in pounds. We put in their age. We put in their sex. We put in the time that they took to walk that 1 mile. And we put in their heart rate in beats per minute. So, for example, for a 25-year-old man with a weight of 170 pounds who walked a mile in 20 minutes and had a post-exercise heart rate of 140 beats per minute, if you plug all those numbers in, we get a VO2 max of 29.2 milliliters of oxygen per kilogram per minute. So then we take that VO2 max value and we go to the table that we used previously, and we say, okay, 29.2. Well, this person's between the 5th and 10th percentile. So basically, this person isn't really doing very well relative to the average for his age. And so we could then recommend an exercise program to increase their aerobic capacity. So walk tests really are quite good. They have some advantages. They use a very common activity. Everyone knows how to walk. They only require a very simple measurement, which is heart rate, which can be done. Anyone can be trained to do that quite easily at the end of the walk test, or you can have someone do it for you. And it's easy to track fitness improvements over time. In other words, it's simple enough that an individual could even do this test on themselves over time and see if they're improving or not in terms of fitness. One disadvantage is it really does require an all-out effort. Even though the person's walking, they're essentially speed walking. And so, again, if someone does have some sort of cardiovascular risk factors or other risk factors, this might not be the best test for them. But as I said, it's quite good. As fitness improves, they should see changes in heart rate, and so their heart rate at the very end should become lower, and the time at the very of completion of, say, the mile walk should become lower. And so they'll see nice improvement there, which is very nice. And this, of course, will give them a higher estimated VO2 max and so that's very encouraging as they see the progress there. As I've mentioned a few times, the big disadvantage of many of these tests is they require maximal effort. Even the walking test requires that they walk essentially as fast as they can for that 1 mile. To get around this, a test has been developed called the Modified Canadian Aerobic Fitness Test, or mCAFT. And this test very cleverly gets around this idea. In other words, the individual will stop exercising before they get to their maximal value. So the way this works is it uses an 8-inch steps to evaluate cardiorespiratory fitness. So you could use, as shown here, these are sort of fake steps, but you could actually just use regular steps. And they're going to start at ground level, move up 2 steps, and then step back down. And what you'll do is first you'll look at a chart and you say, well, okay, for a given age and a given sex, what's the starting stage? And there are different stages, numbered 1 through 4, and these correspond to different cadences. So then you'd start them off at that minimal cadence, and they're going to listen to a recording that'll help them with the timing that they have to keep up with. And then what they'll do is they'll start at a certain cadence and continue for 3 minutes. And at the end of the 3 minutes, they'll stop, and someone will help them by recording their heart rate within 15 seconds after they stopped. And it takes about 10 seconds to record the heart rate. Then they record that, and then the person starts the stepping again at the next higher cadence. So they're going to go up another stage. A stage has a particular cadence, and they'll do that, and then they stop, and then the heart rate is measured again, and keeping track of the heart rate. And eventually you'll get to a maximal allowable heart rate based on the age. So for example, you might say, well, we want to end this test when you get to 85% of your age predicted maximal heart rate. So in other words, you're never going to get to 100%. And so this is safer, right? Because you never push the subject to the 100% of their maximal heart rate. And then once you have this data, you use this formula. So VO2 max can be estimated this way. So VO2 max equals 17.2 plus 1.29 multiplied by VO2, and then you have 0.9 multiplied by the mass, and then multiply by the age. So the mass is in kilograms and age is in years. And I should mention, so this VO2 is actually just derived from a table. It's based on the energy cost in the final stage in milliliters, and it's obtained from a table, which I'll show you in a second. So basically, you've measured the person's mass, you have their age, and you have this estimate here based on the last stage that they got to when they reached that 85% of the maximal heart rate. Okay, let's imagine we have a male who's 30 to 39 years of age. So this person, according to this table of 15.2a, would start at stage 3. So then we'd look over here of this the next table and say, okay, here's stage 3. For a male, here's the stepping cadence. It's 102, so that's a certain pace. And let's say they start at stage 3 and they're able to go all the way to stage 5, which is a cadence of 132. Then they would have an O2 cost of 29.5. And so that's the VO2 value that would be plugged into the equation. Let's go into a little more depth and look at an individual case. Let's say we have a 30-year-old woman. She weighs 130 pounds, which translates to 59 kilograms. And let's say she completes stage 5. So we plug in these various values. We have our equation. We plug in the VO2 value based on the fact that she got to stage 5. This is the what is it called? The O2 cost. We put that in there. We put in her weight, 59 kilograms, and we put in her age, so age 30. And then we calculate a VO2 max value of 40 milliliters of oxygen per kilogram per minute. And then we look at table 15.1, and we say, okay, where's 40 milliliters per minute? Okay, it's between 85 and 90th percentile. So she's actually very fit. So here are the take-home messages. Field tests for cardiorespiratory function use natural activities such as walking, running, and stepping. The one difficulty is physiological responses are difficult to measure. In other words, you can't continuously measure things like heart rate. You typically measure them right after, during, say, the 15 seconds or so after, because one problem is the heart rate will drop very quickly. So you have to measure within about 15 seconds at the end of the exercise. But that's relatively easy to do. You measure for say 10 seconds, and you multiply whatever heart rate value you have by 6, and now you have the number of heartbeats per minute. Another problem with these field tests is motivation plays a key role in the outcome. So some people are obviously much more motivated than others, and so that'll end up skewing the what our estimated cardiorespiratory function is for the person. VO2 max estimates are made from all-out run tests, and these are based on the fact that there's a linear relationship between running speed and oxygen cost of running. One very useful test is the modified Canadian aerobic fitness test. This is a step test that uses steps to evaluate cardiorespiratory fitness. And as we just discussed, one of the big advantages of this is you stop at 85% of the estimated heart rate based on the person's age. So it's a sub-maximal exercise. You never really have to push the person up all the way up to in order to estimate VO2 max. Another thing that's come out in more recent times is that there are criterion reference standards for VO2 max that are available. And these are really preferable to percentile rankings because we're not really interested in ranking, particularly children, one against another. We want to focus on health-related goals rather than comparisons. We're next going to focus on graded exercise tests. These are tests of cardiorespiratory function. They typically use treadmills, cycle ergometers, or stepping benches, as pictured here, to assess a person's fitness. These are incremental tests, so people start off at the lowest exercise intensity, and every 2 to 3 minutes they increase in intensity. Often there's a pre-recorded music or soundtrack with beeps in it, and this helps the person keep pace with the increased exercise. Well, that would be for a step test. Another possibility, of course, with the treadmill is you would increase the pace there. With a cycle ergometer, you'd increase the resistance. Now, another thing about these graded exercise tests is that there's usually a predetermined endpoint that's reached. And that might be a certain work rate. It could be a certain heart rate based on the person's age. The other thing, of course, you would end a test based on the fact that a person showed signs or symptoms of some sort of pathology. And finally, these graded tests can either be maximal or submaximal tests. And the variables that are measured include heart rate, blood pressure, and VO2. Heart rate is relatively easy to measure. It can be measured by palpation, which means you use your fingers during a physical exam. And so this could be done on the carotid artery, as shown here in this picture, or it could be done on the radial artery within the arm. So that's relatively easy. Typically, you might measure for, say, a certain period of time, like, say, 10 seconds, and then multiply by 6 to get the number of heartbeats per minute. You could also use an ECG and display the heart rate on a monitor and measure it using a computer. Potentially, you could also use a stethoscope if you know where to measure, and there are videos on YouTube showing you where to listen to the heart, and that can be another way of measuring heart rate. So during exercise, at steady state, it may be possible to measure the heart rate by palpation. So let's say the person's on a treadmill, then you maybe a second person might be able to measure their heart rate as they're on the treadmill doing the exercise. In this case, you might measure for 15 seconds or 30-second period, and of course multiply by the appropriate factor to get the number of beats per minute. If you're doing an exercise like some of the ones we mentioned before, where you exercise and you really don't have any easy way to measure the heart rate as you're exercising, you would then measure it at the very end of, say, the 1 mile walk or run. And you need to measure it within the first 15 seconds. That's because the heart rate drops very rapidly. And so the way to do it would be to measure for 10 seconds and then multiply that whatever value you got by 6 to get the number of beats per minute. And we've measured blood pressure before in lab, but this is measurement by auscultation, which is the indirect method that was developed by Korotkov, which pretty much everyone uses. Blood pressure can be measured during walking or cycling. And the one caveat is the subject should not be holding a handlebar. And so someone else could help them measure their blood pressure as they're, say, walking or cycling. The systolic blood pressure would correspond to the first Korotkov sound, and the diastolic pressure corresponds to the fourth Korotkov sound, which is where there's a change in tone and it changes to more of a weak muffling sound. Or you could simply take the diastolic pressure to be the point at which there's no sound. One of the problems with trying to diagnose coronary heart disease is it's often a little bit of a silent killer. In other words, people don't necessarily know they have coronary heart disease. As we mentioned earlier, there are some things that would give you an indication that they might have the beginnings of coronary heart disease. So, for example, if a person at rest is hypertensive, they have a high blood pressure, that would be a pretty good indicator that perhaps they're, have a bit of coronary heart disease, at least beginning. But it's really actually a little bit difficult to really know at what stage they are. So graded exercise tests may actually be used to diagnose coronary heart disease. And the reason is when you're at rest, even if the coronary arteries are a bit blocked or there's some other problems, we have sufficient blood flow that there really isn't much difficulty. But it's only when you really push the person a little bit and stress them a little bit that you start to see some irregularities arising. And this could be helpful in terms of diagnosing coronary heart disease and then figuring out what kind of treatment should be started. So when a person's exercising, of course, the heart beats faster and stronger, and it requires more oxygen. And this is when you start to see some possible problems. So one estimate of the amount of work that must be done by the heart, and therefore the metabolic needs of the heart, is called the double product. The double product is the product of the heart rate and the systolic blood pressure. These two things multiplied together, individually, they both increase with the exercise intensity. And so when you multiply them together, it gives you a very good estimate of the myocardial oxygen demand. Furthermore, as you stress the heart a little bit with some exercise, you may see arrhythmias. These are irregularities in normal electrical rhythm. So one type of arrhythmia, for example, is atrial fibrillation. Atrial fibrillation is a situation in which the heart's upper chambers, the atria, beat chaotically and irregularly and out of coordination with the lower chambers, the ventricles of the heart. Another possibility that might arise when you stress the heart a little bit with exercise is there may be premature junctional and ventricular contractions. So these, for example, premature junctional contractions are premature cardiac electrical impulses that originate from the atrioventricular node of the heart, or the junction. So recall that normally the heart is paced by the sinoatrial node, the SA node, and the AV node simply conducts, helps to conduct. It resides within the right atrium, and it attaches to the bundles of His, which are also called the atrioventricular bundle. And that bundle sends the electrical signal, which is the action potential, from the atria into the ventricles. But the atrioventricular node has the job of having a fairly slow conduction velocity. And so it allows the atria to contract first before the ventricles. Now, it turns out the atrioventricular bundle itself does have rhythmogenic properties. So occasionally what can happen is normally it's behind, it has a slower rhythm than the SA node. And so if the SA node always essentially controls the AV node, but occasionally there may be a slightly abnormal situation, and the AV node will generate an action potential before the SA node. And that's what leads to this premature junctional arrhythmia. And the other possibility, of course, is you may have premature ventricular contractions. And this is where extra heartbeats begin in the lower chambers of the heart within the ventricles. Finally, there may also be conduction disturbances in which depolarization is slowed or blocked between the atria and the ventricles. So all of these are things that can be seen with the ECG. It's possible that you may see them in a resting state, but it's more likely that you might see them when you stress the heart a bit by having, say, the person on a treadmill or having the person on an exercise bike with all these leads. It's typically 12 different leads that they would have on their body. Alternatively, there are actually some situations in which you might see some sort of irregularity in the heartbeat at rest, and then as you stress the heart, it'll actually go away. So in either case, the ECG combined with exercise is very useful in a diagnostic setting. A major risk factor for a heart attack is myocardial ischemia. So as I said, normally when a person's at rest, they may have adequate blood flow even through coronary arteries that are partially blocked. But if you stress the heart a little bit with a stress test, say they're on an exercise bike while recording an ECG, you may see some signs that they're in fact suffering from myocardial ischemia. And so ischemia, of course, is inadequate perfusion of the myocardium, meaning there's not enough blood going to the myocardium. Now, in the short term, that might not damage the heart, but if it's allowed to go on long enough, it may actually lead to damage. And that would be an actual heart attack when there's cells die and there's necrosis and so forth. So some of the symptoms would be angina pectoris, which is essentially a pain in the chest. But the pain is not always located directly where the heart is. So it might be where the heart is, but it could also be in the neck or even part of the face, into the shoulder, and into part of the arm, and even into the fingers. And this is this kind of strange distribution. Of course, the pain really is coming from the heart, but this is called referred pain, and it has to do with the way the nervous system is organized. So essentially, your body has trouble distinguishing exactly where the pain is coming from. And so it assigns the pain to an area where it's really not coming from. So these are typical type of angina pectoris, and it's a clear sign that there's some sort of ischemia going on. I should mention, though, that the symptoms are often different in different people. So, for example, in women, they may actually experience nausea, breathlessness, abdominal pain, and fatigue. So, of course, these are also signs of some sort of ischemia, but it's not as obvious. It's not the sort of classic symptoms you would normally associate with some sort of cardiac event. Now, if the person is hooked up to an ECG machine, so they're recording the electrocardiogram, you can look at the ST segment, and a sign of ischemia is that the ST segment is depressed. So remember, this is the we have the P wave, then the QRS complex, and then the T wave. So QRS is the last part of this QRS complex, and so we can look at the ST segment, which is a space between essentially the S and the T waves. And normally it should be right about at baseline, but with ischemia, it'll actually be depressed. In other words, it'll be displaced lower than it should be. And so that's a clear sign that ischemia is going on. So one thing we haven't talked about so far is how the subject who's doing the exercise feels about the exercise they're doing. And this can actually be very important. It can give you some idea that the subject is nearing exhaustion and maybe you should stop the graded exercise test. It can also be helpful for prescribing the level of exercise intensity for them once we go beyond the test and we want to actually start prescribing what kind of exercise they should be doing and how often and how intense and so forth. So there is one of the most common measurements is this Borg's rating of perceived exertion. So rating of perceived exertion is RPE. So the original scale was from 6 to 20, which seems very strange, right? But it has to do with the fact that the heart rate would go from 60 beats per minute at rest up to about 200 during exercise. This scale has been revised to a new scale that starts at 0 and goes to 10, with 0 meaning not exercising at all the way up to 10 being very, very heavy, almost maximal exercise. So this scale is an indicator of subjective effort. So it's a way to track progress through a graded exercise test. Again, you might want to stop or have an endpoint once a person reaches a certain number for the perceived exertion, rating of perceived exertion. In order to do this, because everyone's perceptions are different, they're read, and it's in your book. There's a paragraph which that they're provided with telling them what they should pay attention to in order to try to make the results of this sort of subjective reporting at least a little bit more consistent. And so one of the disadvantages, of course, which I've already sort of touched on, is this is perceived effort. And so there is a large difference between individuals in terms of, what their perceived effort is. And you can see this by measuring this rating of perceived exertion and then looking at the actual heart rate values. And you'll find that for certain individuals, they may not even have that high of a heart rate, and yet their perception is that they're, exercising at this incredibly high rate, whereas another individual may have a high heart rate, which indicates pretty objectively that they're working very hard, and yet they might not perceive it as being that hard. So you have to take this sort of rating with a little bit of a grain of salt, and yet it's still useful. It tells you a little bit about how this person is perceiving the exercise. And it can, as I said, help you determine exactly when you might have a stopping point for a graded exercise test, and it might be helpful in prescribing exercise later on. When doing a graded exercise test, you should always figure out what the termination criteria are ahead of time. So obviously certain signs and symptoms that there's some sort of cardiac event going on, such as ischemia, or there could be a respiratory event such as shortness of breath. Those sorts of things would obviously terminate exercise very quickly, or just an overwhelming feeling of exhaustion. So the participant in the test should be told, well, if you feel any of these things coming on, obviously you should stop at that point. And so the termination criteria certainly depend on the population being tested. If you have someone who's very young and healthy, and they have absolutely no signs or symptoms and no pre-existing conditions whatsoever, well, then they could be pushed to go further to actually get very accurate measurements of VO2 max. For someone who does have, say, cardiovascular disease or some other risk factor, then you would need to set the termination criteria appropriately. And it also depends a bit on the purpose of the test. Are we trying to collect scientific data, or are we just trying to figure out what the next step is in terms of an exercise program for this individual? So the American College of Sports Medicine, ACM, has guidelines for exercise testing and prescription, so that they would certainly be the ones to turn to look for that. But here's some general indications for stopping exercise in low-risk adults, okay? So obviously there's other tables for high-risk adults, but let's say we have a low-risk result, onset of angina or angina-like symptoms. So again, that's the pain within the chest, neck, or arm, or any of those other things such as nausea, or any of those things might indicate that there's some sort of hypoxic event or ischemia within the heart itself. A drop in systolic blood pressure of greater than 10 millimeters of mercury from baseline, despite an increase in workload. That's a bad sign if the systolic blood pressure goes up. An excessive rise in blood pressure, if it goes above 250 millimeters of mercury, then that's very high. Or if the diastolic pressure goes above 115 millimeters of mercury, these would be signs to stop immediately. Shortness of breath, wheezing, leg cramps, or claudication would be bad. Signs of poor perfusion, such as lightheadedness. Okay, that's an indicator you're not getting perfusion of blood to the brain. Confusion, again, not enough blood to the brain. Ataxia, ataxia is a loss of full control of body movements. Again, that's going to be a brain perfusion thing. Pallor, so if someone suddenly their skin becomes quite white, that's an indication something's going on. There might be overstimulation of the sympathetic nervous system, which would direct blood away from the superficial layers of the skin, which might be an indication that something bad is going on. Cyanosis, that's a bluish discoloration of the skin, which results from poor circulation or inadequate oxygenation of the blood. Again, that's a big sign that something is not going well. Nausea, as I said, could indicate, the person might be exhausted, but there might actually be an ischemic event going on in their heart. Cold or clammy skin, again, this is an indicator. Cold or clammy skin typically would be indicating that something's going on with the sympathetic nervous system. If it's cold, that's because blood is being directed away from the skin, and it's being directed to the heart and to the brain and the respiratory muscles. So it's essentially that happens when the body's trying to conserve energy, and so that's a bad sign. That means the person's should certainly immediately stop. Another possibility is failure of the heart rate to increase with increased exercise intensity. That means, remember, the heart rate should be linear with exercise intensity. And so if it doesn't continue to go up linearly and it's sort of plateauing, that means the person's already reached their maximal heart rate. They can't go up any higher, and you should certainly stop at that point. Noticeable change in heart rhythm would be another thing. If the subject requests to stop, that means they should stop. Physical or verbal manifestations of severe fatigue, and of course, failure of the testing equipment. So all these things would indicate you should end the test. So our take-home messages are typical measurements obtained during a graded exercise test include heart rate, blood pressure. We can do ECG, electrocardiogram, and rating of perceived exertion. Specific signs, for example, fall in systolic blood pressure with an increase in work rate, and symptoms, for example, dizziness, are used to stop graded exercise tests.